topic is sickle cell disease. Who you really want to talk to is Dr. Griffin Rodgers. He is widely recognized for his contributions to the development of the very first treatment for this, and he also has done a lot of the basic research in sickle cell. And he also, by the way, happens to be the director of the National Institute of Diabetes and Digestive and Kidney Diseases, NIDDK, and the chief molecular and clinical hematology branch of the NIH's National Heart, Lung, and Blood Institute. Near and dear to me, by the way. I appreciate that. Thank you very much for chatting. The question that I have for you is, you just came out of a session on optimizing therapy in sickle cell disease. Before we talk about that, where are we right now with sickle cell in the United States?
Well, I think we're in a good position. There are, first of all, you should know that in contrast to 30 years ago, the average life expectancy for a patient with sickle cell disease continues to improve. And in large part, this improvement is based upon the types of government-sponsored research that has gone into this. Understanding that, for example, prophylaxis for childhood infectious diseases accounts for a great majority of that improved longevity. And some of the therapies that were just discussed at the session on optimizing care of patients with sickle cell disease has also contributed to better life expectancy.
With life expectancy improving, we're doing something right. What can we do better? I know pain was one of the issues that you talked about.
Yes. Well, there are available therapies that many patients or their providers or their family members are either unaware of or have limited access to, that we already know from the results of research can improve both the morbidity, pain, and other complications, as well as the overall survival. Hydroxyurea that you referenced earlier on being one example of that. It's only estimated that perhaps on a very optimistic basis, about 30% of patients who could benefit from the drug are actually taking it. And so maybe getting the word out to both providers as well as patients as well as their families might be one means of doing that. The American Society of Hematology has taken a very aggressive, forward-looking stance to try to educate both the providers at these sessions as well as on some of the regional activities that they're involved in. And of course, at the National Institutes of Health, we're also in the process or have been continuing to use social media and other ways to educate the general public.
Why is the number so low? That was one of the questions I had written down. It's like, why?
Why? Well, this drug in particular, hydroxyurea, is one of the drugs that's been around for quite a while. It has, in the 50s and 60s, been used for the treatment of either leukemia or pre-leukemic conditions like polycythemia vera, for example. And there are still individuals who think using some form of chemotherapy to treat what's considered a non-malignant disease is one barrier. One has to understand, however, that there are other forms of chemotherapy, for example, methotrexate, that's being used to treat, for example, psoriasis, and there are other examples of that. And so that notion that because a drug was developed for a particular indication, that forevermore that's the only approved use or use that should be considered, we have to kind of quash that notion.
In terms of other issues that were addressed, what do we need to know?
Well, again, this session on optimizing therapy looked at some of the issues and some of the frequent complications associated with patients. Pain being one. In what setting does one have to consider the fact that cumulative damage to the central nervous system causing neurocognitive impairment, and how that might relate to education activity of young kids and career choices. It also dealt with issues related to clotting and the risk for venous thromboemboli and how to both diagnose and appropriately treat. It also, again, discussed issues related to what we know now and, again, what's not being utilized as effectively. Again, hydroxyurea being still the one and only FDA-approved treatment in adults, not yet for children. And then finally, we sort of looked at what the future might involve in terms of the use of other drugs that, while they don't treat directly the underlying hemoglobin disorder, the sickle manifestation, it may target some of the more downstream complications associated with the vaso-occlusive disease.
I mean, one of the speakers said more and better therapies are desperately needed. So what were the ones that you talked about?
Yeah, so I think what he was addressing were some of these downstream targets. We know that not only is this a disease that affects red blood cells, but because of some of its secondary complications, it activates the coagulation system, it activates white cells and the inflammatory pathways, and maybe targeting some of these coagulation or adhesive phenomena associated with the disease, as well as the inflammatory component, may be a way to either directly treat patients in acute vaso-occlusive crisis or potentially to prevent them from having it in the first place.
Having done clinical trials yourself, having been done some of the basic research, are you optimistic at this point? Where are we going in the near term in terms of therapy and treatment?
Yeah, well, I would sort of characterize it in sort of three stages. One is, first of all, this is the first disease to be understood at the molecular level, the first genetic disease, as it was coined by Dr. Linus Pauling in 1949. And so not only do we know the protein abnormality, we also know this genetic underpinning, and we have ready access to the stem cells of these patients in the form of the bone marrow or peripheral blood stem cells. So treating the upstream complications is an area of active investigation. At the moment, the most effective way to cure the disease is to do a bone marrow transplant. And there are several varieties of that, including one from our own group with my colleague John Tisdale and Matthew Shea and others, developing what's called a less myelosuppressive form of transplant therapy. That, in conjunction with other transplants, are certainly going to likely be applied to an increasing number of patients. But sadly, only about 25% of patients who could benefit from this have sibling donors that are identical matches, and that leaves a vast number of patients still ineligible. However, gene therapy, in which one could take one's own bone marrow or stem cells, modify it in a way so as to counteract the effect of the sickle mutation, is really what's happening in the future. In the meantime, using drugs that combat the sickling or the polymerization of sickle hemoglobin, such as hydroxyurea and other agents, seem quite promising and are highly effective, both in children, as we heard in this session, as well as in adults. And then thinking about some of these downstream complications that we heard, targeting the coagulation system, targeting the adhesion system, targeting the inflammatory system, seem to be other possibilities. And in some sense, it may not be just one, it may be combinations of therapies at different times that may ultimately solve the problem in the vast majority of patients. We also have to think that this is a disease that, while there are 100,000 or so individuals in the United States, maybe North America might increase that number by about 50% more. These are largely diseases of developing countries. Yes. And so we have to think sickle cell disease and its related disease, thalassemia, in which the same interventions might be effective. Large patients in India, for example, in the Middle East. We have to think about therapies that would be quite cost effective in those low resource environments as well.
Well, thank you, because NHLBI and NIDDK do such great work, and so when I saw you here, it's like, oh, please, let's chat if at all possible.
Well, thanks for having me. It's good always to share what we know, and certainly we would recommend your audience not only to keep abreast of what ASH is doing in this arena, but visit our NIH website to learn what our respective institutes, NIDDK and NHLBI, are doing in this regard.
And as you probably can guess, we are at ASH 2015, and I'm Rick McGuire.